In this month's Practice Up, we're going to talk all about selenium. What is it? Are we really as deficient as people say that we are? How do you test it most accurately? And when you do, what are optimal levels? Who should be supplementing with it? And if you give your patient selenium and they don't need it, what could possibly go wrong? It's not very good, but I'll give you a hint. It starts with insulin and it ends with resistance. All that and so much more in this month's Practice Up. So, how do you evaluate selenium status and when to supplement? I'll just go ahead and tell you, you can test it in the hair, in the urine, in the blood, and very often is used in the toenails. I'm not sure of a lab that collects toenails, but I guess it's better than stool. So, according to the papers that I've looked at, well, first of all, urine selenium is not even worth it. Okay, hair, we might talk about later, but blood is used most often. Now, is it a perfect marker? No, but like I said, there's very few perfect markers. Selenium, some people say it might act as a negative acute phase reactant, goes down in inflammation. I'm not going to touch on that, but what I am going to show you is the convincing and compelling argument that serum selenium concentration is adequate enough in order to know what somebody's selenium status probably is, as well as when you might want to supplement with it. So here's a paper from looking at NHANES 3 data, which is a while back now. Increased serum selenium levels are associated with reduced risk of advanced liver fibrosis and all-cause mortality. Well, wait a minute. And people that have non-alcoholic fatty liver disease. Wait, what? Is this backwards from what I'm saying? The risk of advanced liver fibrosis, everybody in this paper had non-alcoholic fatty liver disease. Okay? The risk of advanced liver fibrosis is inversely associated with serum selenium levels, all-cause mortality decreased with increased selenium levels. Isn't that just the opposite of what I just said? That you don't want it to be too high? Interesting. Actually, okay, well, first of all, if you have patients with non-alcoholic fatty liver disease, it seems that higher selenium might be a little bit better. But I'm showing you this paper for a different reason. Look at this. The higher the selenium level, the lower the fibrosis score. You can see that. But here's what I really wanted to show you. They broke people down into quartiles based on their serum selenium levels. You can see that at the top. People less than 113, quartile 1. People greater than 133, quartile 4, you can see. But I want to show you, there's a point to this, okay? So whereas higher selenium levels may have been more protective for people with non-alcoholic fatty liver disease and decrease their risk of advanced liver fibrosis, their selenium levels here, you can see the mean was statistically significant. The highest level there was 145. Quartile 3 was about 126. Quartile 2 was about 117. And quartile 1 was about 104. I just highlighted their BMI. Look at this. It was statistically significant. The quartile 4 with the highest BMI, the highest selenium had the lowest BMI. Really weird. Their A1C, this is what I was going to get to, was 5.8 versus essentially 6 in the first group. That's considerably higher. And notice the other groups was about 5.6 all up until quartile 4. The higher the selenium, the higher the A1C. Also, and they didn't report on this in this paper, CRP was lower, which is really interesting. Not terribly, it was statistically significant. The lowest quartile was 0.7 all the way down to 0.4. That's a pretty decent CRP for somebody with non-alcoholic fatty liver disease. But the higher the selenium, the lower the CRP. Now, most people will say that and say, well, you need to increase your selenium. Okay, well, you lowered your CRP, but you raised your A1C. Is that really what you want to do? And then look at metabolic syndrome. 554 people in quartile 4 had metabolic syndrome versus in the lower groups was 400, 500, 400. And then lastly, look at the fasting plasma glucose. The highest quartile had a fasting plasma glucose of 110, and the lowest one was 104. You see the connection here? Too much serum selenium is associated with insulin resistance, type 2 diabetes, metabolic syndrome. One other thing that I just couldn't resist showing you. Every single person in this study had non-alcoholic fatty liver disease with varying degrees of fibrosis, okay? Every person in this paper has non-alcoholic fatty liver disease with some element of fibrosis. Check out their ALT, okay? 19, 23, 23, like that is well within the limits of a standard reference range, which is why I teach an optimal range. In level 3, I go into this in greater detail. You will not find somebody with fatty liver looking at ALT, period. I've seen more studies, this is a different topic, more studies, in case you haven't done any other courses. Don't look at ALT for fatty liver, because people are in your office right now with fatty liver that have normal ALTs, period, end of story. There's plenty of studies like that, which incidentally is why I'm probably going to be doing a fatty liver workshop coming up. All right, serum selenium levels in all-cause cancer and cardiovascular mortality among U.S. adults.